Professor Ziaul Islam is not, Zafar Iqbal is not here. So we'll start with our first presenter. I guess our first presenter is also not available. So I'll request Dr. Shabana Chaudhary to please come up on stage and give her presentation.
Good morning and assalamu alaikum to all of you. Today I'm talking about something new, adventures which we have done in our setup in New Hospital. I'm Dr. Shabana. I'm leading consultant in pediatric ophthalmology in New Hospital.
Dr. Shabana,
Retinoblastoma
Mike.
is very uncommon. Retinoblastoma is uncommon. Retinoblastoma is uncommon, but not very uncommon at the same time. So, बेटे वो दीजिए मुझे. No financial interest to this. It was a situation being mentioned in literature where the survival rate of retinoblastoma was only 45% in Pakistan, and the presentation of metastatic disease at diagnosis was 40%, which was very high as compared to the other countries. The learning objective of my, I think, there was a journey of tears, fears, hope, and faith. It was a condition where we used to do excentrations, enucleations, a lot many enucleations. But now we are switching over depending on our presentations as well as the grading and grouping and networking of retinoblastoma. We in this presentation we will be able to learn about the updates and share the info about the available treatments in Pakistan. I'm going to present a case of a 9-year-old female. She presented to us on 23rd of October 2019, a very precious child who born after 13 years of marriage. She presented with the hypopion. Her VL acuity was 624 at presentation, which improved to 618 with the IOP of 41 millimeters of mercury. And the iris showed the fluffy mass. You can well appreciate it. On B scan, there were intragel hemorrhage, but there was no intraocular calcification seen. Retina was in situ. That was a catch. First, the presentation of the child age was the catch. The second catch was no calcification on B scan. According to our SOPs, we did the EUA, and it shows the IOP of 22 millimeters of mercury. Mobile hypopion, because the hypopion just the level you have seen that is now dispersed. There was a infratemporal lesion seen on I don't have the fundus photographs of the first day, and the macula was uninvolved, but whole of the periphery was involved. This is the picture. We tried to get the picture. It's not very good quality because we asked the child to sit on the camera, and we don't have the red cam at the moment in our department. The age, the presentation, and I was thinking what it could be. The differential diagnosis in pediatrics, inflammatory or autoimmune disease, which can lead to the hypopion, infectious diseases, neoplastic diseases, but the common pediatric masquerades, retinoblastoma, coarse, juvenile, or posterior uveitis. That was the dilemma actually, because it was very difficult for us to evaluate the patient and said that it's retinoblastoma because the age was the problem. The VN was the problem. No calcification was the issue. These are the basic things on which we clinically made the diagnosis. Uh, with consultation cover up our to cover up, we give the Canaccord because if we thought that if it's the inflammation, then maybe it improved. Yes, we did. We in the slide, I didn't say that, but I mentioned that we rule out everything because we sent the patient to pediatrics. So we did all the labs, everything. MRI shows the plaque-like enhancing mass in intraocular, and it was unplaque retinoblastoma without the optic nerve involvement. So we made the diagnosis of retinoblastoma, and we started. First, I discussed it with the other consultants from Ashifa, from LGH, who were doing the retinoblastoma thing because without collaboration, it's difficult to manage retinoblastoma, and that in such cases there is no harm discussing it with the other consultants as well, just to have the second opinion. And in literature it is mentioned about the unplaque retinoblastoma. According to the classification, it was group E. We use IIRC classification. According to that, it's group E. And we what to offer, because in group E we do enucleation. How many of you would say, okay, we will go for enucleation? We should go for unilaterality. Group E. I was having a hypopion. So what do you think? Should we go for enucleation or not? Okay. So if we go according to the classification, we had to enucleate the eye, but the patient refused. The offers we gave to the parents were globe saving treatments, selective intraarterial chemotherapy or intravitreal chemotherapy, and the extensive counseling was done about each treatment with the parents. Parents refused enucleation. Parents opted for intravitreal chemotherapy and systemic therapy. They refused intraarterial as well. And we started the patient on intravitreal chemotherapy under the cover of systemic chemotherapy. We gave 0.2 ml of aqueous tap was done, and intravitreal melphalan 0.03 milligrams were given. With the method of giving intravitreal chemotherapy, it's slightly different from the other intravitreal injections. Then through the process of 6 months, we gave 4 intravitreal, 2 intracameral, 2 subconjunctival melphalan. Focal therapy was done, lasers, cryo, at the same time to the periphery. Systemic chemotherapy, we gave Joe chemotherapy, vincristine etoposide carboplatin. On the 5th cycle, the child had cardiac arrest due to the complication of chemotherapy, and the oncologist said that we won't be able to give another cycle, so enucleate the eye. At that time, it was like again, it was very difficult for us. So we give the parents option, and they said no, we will give another cycle, but we won't enucleate the eye. This is the photographic journey, and this is all the photographic journey, a combination of last 2 regression phases. In November last week, the patient presented a follow-up with the VN of 612, and this is the last fundus photograph with group 3 regression. Patient survived, and alhamdulillah, no mets, nothing, with good VN, and so the miracle happened. Thank you very much. Yeah, sure.
I'm sorry, I'm a little late.
Yeah,
I'm
yeah.
really
The
sorry.
last one, the last B scan which I had.
No, the initial B scan.
Initial, yes, that was the initial one.
No,
The one which I showed you here. वो दोबारा ऑन कीजिएगा. बेटे वो
Okay, so what I want to say here, this is definitely Group A by all, Group E by all means, because there's anterior segment seeding. But I think very soon, even this classification will be revised, because what retinoblastoma entirely depends is the main tumor mass. If you've got a huge endophytic tumor and it's occupying most of the vitreous cavity, then there's no point saving the eye. Now, if you look at this main tumor, it's a very small tumor, which is giving off a lot of vitreous seeds. And you can see the lens is clear, and there's just anterior segment seeding. So I think the prognosis in this eye would be good. I mean, I would expect.
No, it's not the group A. It's not the small tumor. It was it was the small tumor. Small this इधर नजर आ रहा है, but it was plaque and 360-degree plaque tumor.
Whenever there's anterior segment seeding, even if you had done a UBM on him,
Yeah.
even the ciliary body would have been full of seeds.
Yeah, we did.
Actually, the seeding that's going, it's not the main tumor
Yeah.
that's infiltrating, it's the seed. And some tumors love to give off seeds.
Yeah.
They're going to be small tumor, and sometimes very big tumors don't give off seeds. So when they give off seeds, melphalan works wonders. That is true. The second thing I want to say here is, why would you do an aqueous tap in this patient for an intravitreal? Because the reason why aqueous tap is done is to lower down the pressure. But you see here, the anterior segment is already full of seeds. So that is going to be a nidus for the seeds to come out, and it can cause orbital seeding. So did you do cryo on the cornea when you did
Yes.
anterior?
Yes,
okay,
we did.
So that was the
We
important.
did. Video में मेरी sorry for my editing capabilities. अब वो थोड़ी कम है. But we did everything. We did every measure we could take, because we offered. First, I was like in a favor of enucleation, but the parents totally refused. She was the only child, and after 13 years of birth, and she said that they were not in favor of that one. And then we take every measure and literature research. I discuss it with Shield as well, with Didi as well, Ashwin. So they were all on board, and then we started it. And it's the 3 years data now. It's the 3 years post-op, without any meds and without anything.
That's good. But I think if I were you, I would probably not do aqueous tap, because even now a lot of my melphalans I don't do tap. I just give AZM beforehand, and I give topical beta-gan, because I think in retinoblastoma I don't like unnecessary punctures. I feel like, so I think that step can be avoided.
The thing is that if you do it, we give 2 cycles of chemotherapy, systemic chemotherapy first. Then after that, we did all the procedures.
Yeah, but then the chemotherapy doesn't come into the vitreous, and it doesn't come into the aqueous.
Yeah, we'll discuss. Yeah, we'll discuss it later. Yeah.
Okay. So my topic is adjuvants in the treatment of retinoblastoma, and half my work is already done by Dr. Shabana, so it makes my life easier. Okay, so this is a case of a 3-year-old child who came with bilateral retinoblastoma. The fellow eye was group E and therefore enucleated. This is a group B eye with huge tumor masses, as you can see. So, of course, the first step is to administer intravenous chemotherapy. And so after 4 cycles of chemotherapy, this is what we have. And I'm not expecting that any more cycles will do anything else to this tumor. So the rest is all on the shoulders of us ophthalmologists to reduce this tumor mass. So here we first tried green laser, but the outcome wasn't so good. And then we switched to diode laser. A diode, the penetration is very good. And if you work with long durations, it works very well. And sometimes you can even see the tumor bubbling. So I went on a used diode laser in excessive amounts. I think it required like at least 6 to 7 sessions, and we were able to control the tumor. This is another case of a child who was referred to me for enucleation. This child was already treated at a private sector, had already received 6 cycles of chemotherapy, 2 sessions of intraarterial chemotherapy, and now the child was advised enucleation and came to me for a second opinion. Now the tumor that you see here is entirely nasal. The fovea is spared, there is good potential for vision, and none of us would want to take out an eye like that. The child had started to develop amblyopia, and you can see the right eye is deviated. So what we did was, fortunately, the tumor is quite anterior, as you can see, and cryo works very well. Cryo works way better than any laser. So I started taking help of the cryotherapy and then administering intravitreal chemotherapy. And you can see that after several sessions, we were able to control the tumor. This is a lot of vitreous seeds. And so what I want to highlight here is you see the vitreous seeds, they settle down. And what they do is where they fall, they intend to implant. So you should always take care of these areas and not ignore, because if you do, then this is going to be another tumor very soon. So we did focal cryotherapy to the inferior seeds and administered 7 injections of chemotherapy. And you can see the fundus is clear and the tumor is gone. And of course, as a pediatric ophthalmologist, we always worry about amblyopia. So from day 1, I said you have to start patching even if the child can't see. And very soon the child was here with 6/6 vision and straight eyes. This is a second case of a child who's presented with an only eye and with a massive relapse of a group D retinoblastoma. 6 cycles of CVE had already been completed 6 months back. This is the picture of the eye, quite scary. The fundus was full of seeds. There was a huge tumor sitting right on the optic disc, but the child was still running around. So when we started on second-line chemotherapy, because we had no other option, we could not reach the tumor because of excessive amount of vitreous clouds and seeds. And the second-line chemo that we give in our center is a combination of vincristine and topotecan, and it works very well. It's very less toxic than the second-line conventional treatment with cyclophosphamide. And as you can see here, the tumor response was very good. And of course, we also administered intravitreal melphalan, almost 7 injections. And you can see that you saw in the previous slide that everything was good. Now this, unfortunately, this family was in a bondage in a village in Sindh. And the Lord, the whatever you call him, wouldn't let the family go because of all the time they had been in the city. They'd taken their money and now they had no money left. So 4 months later, the child comes back with a massive relapse, again on top of the disc. What do I do now? I've lost 2 lifelines. I've given first line, I've given second line. I've given 7 injections of melphalan. What do I do now? So courtesy of Lahore General Hospital, I send the child for intraarterial chemotherapy. And can you play this video? So, so far we have sent almost 4 to 5 children, and I have 80% success rate in these very difficult cases. And so the process is that femoral artery access is obtained, and then a guide wire catheter is advanced to the internal carotid artery, and the microcatheter is advanced to the ophthalmic artery. Now the major hitch here is you see how the ophthalmic artery is it turns right at 90 degrees. So sometimes your catheters get stuck here. Now you can see here the fluoroscopy is being done to confirm the catheter is advanced higher up, and then it is withdrawn. And then once it's withdrawn, it hooks into this, and then you confirm it with the fluoroscopy again. So Is it doing great or is it stopped? So let me show this to you again. So you see this is this, and it goes up, up, up. And so it's going to be advanced higher. Here higher, and then it's going to be withdrawn back so that it hooks onto this. So see, it's being advanced back, it is hooked on, it's coming back, and there you go, it's right into the ophthalmic artery. And the success behind intraarterial chemotherapy is proper catheterization. If it doesn't get to the ophthalmic artery, it is not going to work. So you will know beforehand if your case will work or not. So far, the interventional radiologist is doing very well at Lahore General, and I'm very happy. So, and now we have started at Indus Hospital, Karachi as well. So now we're going to be doing our own cohorts. Thank you very much for patient hearing. Any questions for later?
About retinoblastoma outcomes, recent highlights.
Assalamualaikum. I'm Dr. Lubna Siddiq, working as Senior Registrar at Lahore General Hospital. And it's my pleasure today to discuss with you the outcomes of retinoblastoma in terms what we can save and what we cannot save. Retinoblastoma is that malignancy that affects very young children. This is the first problem with this malignancy, malignant and affecting very young children. But that is not enough. It is also deadly, it is blinding, and it is disfiguring. Sometimes you may be successful saving the life of a child, but he ends up blind, unable to walk around. Sometimes you may save one eye, but he ends up losing one eye or having exenteration in one eye and causing massive disfigurement with social impacts on the life of this child. Since 1990s, the trends in management of chemotherapy have shifted from radiotherapy to the trends in management of retinoblastoma have shifted from radiotherapy to chemotherapy. Chemotherapy has become the gold standard in the treatment of retinoblastoma. Chemotherapy has many routes to be given. The conventional route is the intravenous route through which we can give first line and second line chemotherapies in the form of JO, CEV, carboplatin, etoposide, and vincristine, and second line drugs. We also have adjuvants which are really very helpful, that help us in cases which are resistant to chemotherapy, showing inadequate response to chemotherapy, or presenting with relapses. So the adjuvants are a key tool of the ophthalmologist to combat with this disease. My job is made easier by Dr. Shabana and Dr. Saima Amin. They have discussed intravitreal chemotherapy and intraarterial chemotherapy, and I do not have to go through details of these procedures. The developed countries have achieved a good survival, which is now exceeding 98%. Many centers have written on retinoblastoma clinics, no child will die of retinoblastoma. No child will go blind of retinoblastoma. Patient survival, modes of presentation, and the role of early presentation are well studied across the literature coming from all over the centers treating retinoblastoma in Pakistan. While international studies are talking about globe salvage and presentations and percentages have been discussed, this is just an example of a study which was conducted at Indus Hospital, Karachi, and it studied the survival in children affected with retinoblastoma. This is one example of the international literature discussing globe salvage in children having retinoblastoma. Visual outcomes of treating eyes with retinoblastoma remain understudied both nationally and internationally. We, being a large referral center, Lahore General Hospital, receiving referrals from all over the country and having a large number of patients presenting with retinoblastoma, that make us say that retinoblastoma is not uncommon. It's really very common because maybe we are gathering the cases from all around. We are studying the impact of different treatment modalities, all of them are chemotherapeutic modalities, on vision preservation and globe salvage in patients with intraocular retinoblastoma. We included eyes which had tumors restricted to the intraocular structures. We excluded all the eyes with optic nerve involvement, with orbital symptoms, proptosis, extraocular motility defects, positive bone marrow, or positive intracranial spread on MRI or on CSF analysis. This study was conducted over 4 years of time from 2017 to 2021, and the sampling technique was consecutive non-probability sampling, and we did this study retrospectively, examining all the retinoblastoma forms that we had filled. Informed consent ethical permission was obtained. We identified 116 eyes of 74 patients that met the inclusion criteria of having tumors limited to intraocular structures. 52 of them were better eyes of these patients, only hope. Other eyes either enucleated or having more advanced disease or exenerated. Group B had worse eyes, with the other eye normal in cases of unilateral retinoblastoma or having less advanced disease in cases with bilateral retinoblastoma. Out of 116 eyes, 49 eyes had either rubeotic glaucoma or secondary glaucoma, ophthalmic eyes, or distorted structural anatomy of the eye. That's why the destination of these eyes was upfront enucleation followed by chemotherapy. So enucleation was the first line treatment in these 49 eyes. 67 eyes, which is 58%, were planned for ocular salvage. Of these, 15 eyes were worse eyes in patients having unilateral retinoblastoma or other eye having better condition. 100% was planned of the better eyes were planned for salvage, and 23% of the worse eye were planned for salvage. The classification was also done according to the International Classification of Retinoblastoma System, which divides these intraocular tumors into A, B, C, D, and E. This table shows that out of the better eyes, we were successful in saving vision in 88.8%. In 9%, we could save the globe, but unfortunately, we could not save any vision. The reason being chorioretinal toxicity in some patients undergoing IAC, the occurrence of cataract in patients undergoing intravitreal chemotherapy with topotecan, we have seen that more. One eye progressed and had a relapse after our period of remission, and we had to go for enucleation. In the worse eyes, we were able to save vision in 18%, that is 12 out of 49 eyes. Of them, 15 only were planned to have salvage. And these eyes needed amblyopia therapy because these children were having good vision in the other eye. So we advised tolerable amblyopia therapy. It wasn't very extensive. It was only 2 hours per day. But we did counseling more and more to be persistent with this 2 hours of day occlusion of the better eye. 3 eyes ended with globe salvage among the worse eyes, and 49 had upfront enucleation. If we see what was the result with different ICRB groups, we can see 100% salvage with group A and 100% salvage with group C, because maybe one eye only is group CI. We have more numbers in group B, D, and E. In group B eyes, we have 88% vision salvage, 9% globe salvage. In group D eyes also we had 80% vision salvage. So group D eyes are no more bad eyes with the advent of IAC and intravitreal chemotherapy. Even in group E eyes, we could save vision in 2 eyes. These eyes were having large tumors. One eye was having very large tumor, and that tumor regressed and the patient became able to see. It was the better eye of that patient. He had a worse group E in the other eye. The other patient had exudative retinal detachment, and it was the better eye of that patient too. Seeing which treatment modality did really help us, we can see that systemic chemotherapy along with focal chemotherapy in the form of indirect lasers and cryotherapy were enough in 24 patients. Of them, 20 had vision salvage and 4 had globe salvage. ISC was required in 24 patients, chemotherapy alone being unenough. And in these patients, we had also high rate of vision salvage and globe salvage. 24 vision salvage and 6 globe salvage. In the group requiring intravitreal melphalan, which gave us very good results, only 4 patients received intravitreal topotecan, as an Indian study said that there is less chorioretinal toxicity with the topotecan, so we started giving that. But we observed another finding. We observed more toxicity with the topotecan, so we started giving that. But we observed another finding. We observed more occurrence of cataract with intravitreal topotecan. So that's why globe was salvaged on 2 eyes and vision was only salvaged in 50%. I don't want to repeat on the numbers. I will just show you a brief story of a group DI. This is a group EI which had a very huge tumor touching the posterior surface of lens, regressed and remained regressed for more than 1 year follow-up. So we conclude with the augmentation of systemic chemotherapy with local therapy broadens the horizon for these patients so that they can see and they can live normal lives.
Thank you, Dr. Lubna. Next talk is by, I'll be presenting. The topic of my presentation is pseudoretinoblastomas or retinoblastoma mimicus. Assalamu alaikum. The topic of my talk is pseudoretinoblastomas or retinoblastoma mimicus. As we all know that retinoblastoma is most common primary intraocular malignancy and mostly children presents under age of 5 years. There are different clinical presentations of retinoblastomas. The children may present to you with leukocoria, red eye. Pseudoretinoblastomas are lesions that present similarities with retinoblastomas. If they are correctly diagnosed, if the retinoblastoma is correctly diagnosed, then we can save eyes and even lives. But if it's false negative diagnosis can cause mistreatment and it can also cause life-threatening treatment delays. So there are different conditions which represents clinical presentations with retinoblastoma. The most common of these are Coats disease, persistent fetal vasculature, and vitreous hemorrhage. These are some MRI findings which are found exclusively in patients with pseudoretinoblastomas. I hope you can appreciate these subfoveal nodules. These are the findings. These are nodules which are found characteristically only in the patients with Coats disease. Intraretinal cysts, these are found also only in the patient with pseudoretinoblastomas. Retinal detachment, I hope if you can appreciate the retinal detachment and this vitreous seeding. These findings are found in the patients with retinoblastomas. Ciliary body deformation, optic nerve atrophy. These are the findings which are found in pseudoretinoblastomas. In this picture, there is a stalk extending from the posterior lens capsule to the optic disc. These findings are also found in the patient with pseudoretinoblastomas. So a patient presented to us with a history of leukocoria, and the child who was 3 months age, and there was no history, normal birth history, and the child was born full term. This is a fundus photograph of the child, the right eye. I hope you can appreciate there's an involvement of all the quadrants of the fundus and the vitreous hemorrhages and the diffuse vitreous seeding. This is the left eye of the child, which was found to be normal. This is the B scan, which is showing a mass involving the vitreous cavity. And these are the radiological findings showing, again, the MRI showing the vitreous mass. So the diagnosis, our diagnosis was retinoblastoma, depending upon the age of the child, vitreous seeding, and the presence of calcification. Another child presented to us again with leukocoria, and the child was 5 years of age, and history was, there was no significant birth history. This is the fundus photograph of the child. As I hope if you can appreciate the subretinal exudation and the vessels, abnormal blood vessels. This is the left eye of the child. The FFA was done, and the FFA is showing the leakage in different quadrants. Then the MRI was performed in this child, and you can appreciate the subfoveal enhancing nodule. So our diagnosis was Coates disease, again depending on the age of the child. The vitreous was clear, there was no vitreous seeding, calcification was absent, and depending again on the FFA findings because of the diffuse leakage from the abnormal blood vessels. The third child was 11th month old, and he presented again with the patients presented to us with a complaint of the child has a small eye and the white reflex. This is the picture of the patient, and this is the fundus photograph is showing a stalk extending from the disc margin to the posterior lens capsule. Sonography. All the patients with persistent fetal vasculature, they have got characteristic ultrasonographic findings. They consist of a stalk, inhomogeneous echogenic stalk extending from the base of the lens to the vitreous, and you can easily appreciate this stalk in this picture. So our diagnosis was persistent fetal vasculature, depending upon again the age of the child, the small size of the eye, the presence of the stalk, and the absence of contrast enhancement within the solid lesion. So the take-home message is the importance of imaging in diagnosing different cases who present to us with leukocoria, because every leukocoria is not retinoblastoma. Thank you. Our last presenter is Professor Zia, and he will be talking about the challenges faced by developing countries.
Bismillah ar-Rahman ar-Rahim. Regarding retinoblastoma, my first article on retinoblastoma prevalence and clinical presentation of retinoblastoma was published in April 1985 issue of Pakistan Journal of Ophthalmology. The PGO at that time, the PGO used to be published from America, for United States of America, and there was a Pakistani ophthalmologist, Khalid J. Awan, and he used to be the editor and publishing the journal. And this is the journal at that time, so we had to publish retinoblastoma in 1985. Apart from PGO articles, I've been published in Journal of Ayub Medical College, in Canadian Journal of Ophthalmology, and so on. We established a supraregional center actually for retinoblastoma. If you want to treat this individually, it becomes very difficult. So it's always better there should be some supraregional center, and there should be a sort of committee which consisting of pediatrician, oncologist, and the ophthalmologist, so they can work together. I'll just mention that we what I did when I was starting this retinoblastoma cases. In that time in Pakistan, it was the highest number in our part of the country because we used to get patients from Afghanistan as well. So this is the sort of study at that time which I did. And the presentation, as you all know, is the leukocoria proptosis fungating mass. Now, at that time, almost we see there was no much awareness about the retinoblastoma, so we used to get patients mostly regarding, and we used to do the investigation test to find out what is the real problem. Investigation test to find out what is the real problem, and as you already mentioned that we had to do the B scan, we had to do the. Now, regarding the treatment, at that time there was much. You see, you all know that in early days we used to do either radiotherapy, there was no chemotherapy at that time, or we do photocoagulation. At that time I had photocoagulation which was known as xenon photocoagulator. And I have used xenon photocoagulator for a lot of patients of retinoblastoma, and still the retinoblastoma survival are there. So nowadays, as you have just mentioned, we have come even to the chemotherapy, and now it's the intraarterial chemotherapy. So advances are getting on. Now, I just want to discuss what are the challenges actually. The dilemma of the diagnosis, delayed diagnosis in the treatment, and the misdiagnosis. You see, normally the delay is that if child has got some problem, the parents they don't pay much attention to it, or they've got no resources to go to a sort of proper center. And sometimes even the ophthalmologist or the general practitioner, when they look at it, they think that it's sort of cataract in early cases of white pupil. And they said, oh, the child is too young, and when he gets older, I will go to an ophthalmologist. Now, deficient equipment related to ocular oncology care in relation to retinoblastoma results in poor outcome. As you all know, in developing countries, you don't have so much facilities. So every ophthalmologist haven't got those sort of facility to diagnose. Now, poverty, as you all know, poverty is one of the reasons that people, they don't take their children to the ophthalmologist. They will go to the general optician, general GPs, and they don't pay much attention to it. They don't refer patient properly. Nowadays we have got this that the pediatrician, when they see the patient, and if they suspect anything, they should refer this to the ophthalmologist. And the illiteracy and cost of the treatment. Now you see, the thing is that if you want to give chemotherapy to a patient, to a child, now if you want to give 6 doses and it costs 70, 60,000 rupees, so it becomes very difficult. So I think it is when the supra-regional center is developed, so their sort of center, they can always arrange this from the Zakat fund or making some sort of donation to help these patients, because most of them, they are poor people. They cannot afford the treatment of chemotherapy. And complication of chemotherapy, as you all know, you have mentioned, so we have to deal with those sort of complication. Now, lack of expertise, lack of expertise, as I said, that you have to diagnose the cases through a proper diagnosis, and problems in enucleation, poor surgical technique. You see, if you want to enucleate an eye, you all know that it should be properly enucleated, because if you rupture the globe, there are chances of recurrence in the orbit. So poor surgical technique, careless handling of the eye globe, particularly rupture or puncturing of the eyeball, and import cutting of the optic nerve. So improper cutting of the optic nerve, this is very important. Now, last biopsies. You see, for example, you enucleate a patient and you don't send it to the lab, or you send it to the lab, and next time when they come, they don't have the report of the biopsy. Poor documentation in surgical OTs and misdiagnosis and so on. So you see, it's very important to enucleate the eye properly. Post-enucleation recurrence. The orbital recurrence, you have to look into the intracranial extension and metastasis, metastasis elsewhere. Now we had some sort of survey on these patients, how many people they get this metastasis and where. Now the lack of communication between parents and doctors, distance residences of patients, peripheral areas in Afghanistan, and loss of documents. You see, this is a thing is that if the parents they want to bring this child to an ophthalmologist, they don't come for a follow-up. Either they are from far away distance or they don't have the facilities to come to an ophthalmologist. So you see what I mean to say, there are a lot of problems. You see, in our part of the country, in the developing country, they want to save the eye of the patient. But in our part of the country, it's not only the eye we have to save the life of the child as well. Now, in this era of technological advances, resulting treatment of retinoblastoma in children, the occurrence of metastasis and unacceptable mortality is a challenge faced by developing countries, particularly when survival rate in these children is approaching 100% in developed countries. The failure to identify clinical and pathological parameters in the course of the disease in retinoblastoma children results in human misery caused by poor follow-up and gross negligence. Now, nowadays, as you just mentioned, the intraarterial chemotherapy is really recent advance, but this is only in those cases if you diagnose them in very early cases. Then I don't think it's possible. But for this, again, you need a proper intervention radiologist to help you in these sort of cases. Thank you very much. Thank you very much. I think we had to conclude this session because there are no more speakers. Now, retinoblastoma, you see in Pakistan, as I mentioned previously, it was not given much attention, but I'm glad really because most of the centers, they are looking after retinoblastoma cases. I used to see 12 to 15 patients per year initially when I started this retinoblastoma collection in early 80s. And nowadays, I don't know how much is your estimate. But the thing is that now every center is now equipped with a lot of the diagnostic facilities, and I think now when I see retinoblastoma, every center is now interested to do presentation, and that's how you see, as you mentioned, that in the developing countries, the outcome is 100%, and I think we have to achieve that target as well. Thank you very much.
Already mentioned about how it's important to have referral centers. And I think the message we should get across are a couple of things. Number one, to have a national retinoblastoma foundation. Somehow it brings all the institutions together. One should not be a competitor to the other institution, but actually collaborate with the other institutions. So come up with national standardized treatment protocols. There'll always be differences in opinions and diagnostic and therapeutic interventions, but like Dr. Sania, is it? Saima, yeah, I could see the passion in her presentation. That I think we should have a national protocol which is adapted from the international protocol but modified to the local needs, whether there is systemic or intraarterial chemotherapy is available. All of these should be audited as well. And I'm not sure how many of your cases are presented in international federations. And we are now forming a new Asian retinoblastoma group, trying to bring all Asian institutions under one control, not control, but as a place where we can present cases, challenging cases, recurrent cases, so that one country from Asia can help another country from Asia, rather than the rich Europeans or the Americans, who have different centers. So I'm willing to work and collaborate with any one of you. And what we do and replicate in Asia is what I think we should extrapolate to Africa. And I think that's where the Afro-Asian Congress comes in. Thank you very much.
Yes.
Thank you very much. And thank you for all your presentation. It is great. And I agree with my friend really about reference center. I'm coming from Europe, but we only have one reference center in Essen, in Germany, for retinoblastoma. It is our shame. And you mentioned that it's human's misery, really, about that. We don't care about that children, about our children to die, to have metastasis of retinoblastoma in 21st century. That is our shame, really. And maybe it will be, as I just suggested, to make one conclusion for this great conference, to make really a referral center in a lot of country, because retinoblastoma, we have every year more cases. What is the real reason for that? What is cause for that? We don't know. But chemotherapy, you mentioned that, Dr. Zia, in early stage of retinoblastoma. What does it mean? That we can save not only a life, we could save a vision acuity. What does it mean? It is very, very important to see and to have the eye. We cannot, all of us who has two eyes, cannot imagine that life in childhood without 1 year. It is big trauma for that child, for all family, and for all of our society. And I think just really, doctor said that we have to make a referral center and to make screening for retinoblastoma. In which age? In kindergarten, we have to make, that is every law in every country has the first examination after a birth, the second one and third, and every year to make exam in kindergarten, to be obligated, to be mandatory ophthalmology exam, because we don't just save eye, we save the life. Thank you very much for all of this.
Yes. Yes.
Thank you very much, all the participants. It's just to update you about the current conditions of the disease. We have a retinoblastoma interest group, which we developed in 2018. We have 3 meetings in the last 5 years. We are networking. There are only 7 reference centers, 3 in Lahore, 2 in Karachi, 2 in Pindi, and 1 Pindi, and 1 in Peshawar. Unfortunately, nothing is there in Balochistan at the moment. So we are all collaborating. We are all collecting the data. We are all discussing the things. There is a good suggestion that we need to come up with to collaborate internationally. We are all our centers are the part of the global retinoblastoma network, and we are as much as we can able to do, we are doing it. Thank you.
Thank you so much for your input. Yes, I will second Dr. Shabana that we have a retinoblastoma task force, and nationally we're collaborating. Like, I'm sending patients, I'm from Karachi, and I'm sending my patients for IC to Lahore, and they're doing it free of cost. So, because all of my patients are very poor. So we are like collaborating, and I'm getting referrals from Balochistan, the other province. And internationally, we have collaboration. The St. Jude's Interest Group has started, and they've chosen some oncologists from here, and they're going to lead that. So that is on the way. And then the new thing now is the adenoviral vectors. So we have collaborated with Dr. Chandata in Barcelona, and he's willing to sponsor our patients, and we're going to be sending patients if they're resistant. So yes, we are working, but I like your suggestion. I think with retinoblastoma, the more we collaborate, the better it is.
This time is my first time to be here. I'm very glad to be here. I'm very inspired by this discussion. And I'm presenting Sub-Sahara area from Sudan. And we would like actually to have a collaboration with this retinoblastoma group. Particularly, we have some difficulties after the COVID-19 with the west part of the world. So we have to look to the east, actually. Sorry, to the west, to the east, actually, to Pakistan, to India, to some countries who have the same problems. For us, even we have difficulties in the most. I think the most something to do is the awareness. We have to raise the awareness, and because of the delay, most of our patients they came late. Most of, as I have been seen here from the presentation of the professor, that why is in our countries patient present for proptosis, and nowadays the most ideal thing is that the leukocoria, or even is very squint sometimes, and a flash of light actually during the early phases of the child for his first day actually of birthday. We have to take care of the red reflex, to learn it to our staff like nurses and home social leaders. It should be, we have to stress on these things, and we are waiting to your help and collaboration. I will particularly take the message from all of you and your addresses from especially, and also from Bosnia. And I hope this meeting, at least I will come back with some promises from you to help us and to collaborate with us. Thank you very much.
Thank you. Thank you for your comments. I think really it's commendable that we should really